For most of the developed world, healthcare is a right, something quietly provided, publicly funded, and accessed without fear. In America, it's a business, and that difference changes everything. The United States spends more per person on healthcare than any other nation on Earth, over $12,500 annually. That's nearly double what countries like France, the UK, or Canada spend. But despite the staggering cost, American life expectancy has been falling. Chronic diseases like diabetes and heart disease are exploding. Medical debt is the #1 cause of personal bankruptcy, and more than 70% of Americans say the healthcare system is failing or seriously broken. The math doesn't add up until you realize the system isn't designed to make people healthy. It's designed to make money. The roots of the crisis trace back to a uniquely American idea, tying healthcare to employment. In the 1940s, as wages froze during wartime, companies began offering health insurance as a fringe benefit. What started as a workaround became permanent. Today, more than half of Americans get their health insurance from an employer. That means if you lose your job, you risk losing your doctor, your medication, and your protection. In no other wealthy country does losing your job mean losing your health care. But it's not just about insurance, it's about incentives. Hospitals in America don't get paid when you stay healthy. They get paid when you get procedures. The more tests, the more surgeries, the more hospital stays, the better the margins. Preventative care, the kind that stops disease before it starts, is underfunded, understaffed, and deprioritized. It doesn't bring in profit. And in a private system, that matters more than outcomes. Doctors aren't immune to this either. Many are paid on a fee-for-service model, meaning they earn more the more they do. Ordering an unnecessary scan, recommending a procedure that might not be urgent, referring patients for specialist care that could have been handled in-house, all of it pads the bottom line. Even well-meaning physicians are trapped in a system that rewards volume over value. Meanwhile, pharmaceutical companies use the American market like a blank check. The US government does not negotiate drug prices, unlike nearly every other developed country. That's why a vial of insulin that costs $6 in Australia can cost over $300 in the US. The result is a country where nearly 1 in 4 diabetics ration their insulin, where cancer patients run out of savings before finishing treatment, where a single ambulance ride can cost more than a month's rent. Even the structure of hospitals reflects profit logic. Non-profit hospitals, supposedly charitable institutions, often act no differently than private ones. They sue patients, build lavish new wings, and pay their executives 7-figure salaries. The tax breaks they receive for being non-profit often go toward expansion, not affordability. In many cities, the largest employer and the most expensive service provider are one and the same: the local hospital network. The consequences aren't theoretical. In the richest country in the world, nearly 68,000 Americans die each year simply because they can't afford medical care. Not because treatment doesn't exist, but because access to it is rationed by income, insurance, and employment. And for all this, satisfaction is lower. American patients wait longer for primary care than those in countries with universal systems. Emergency rooms are overcrowded because people use them for basic needs. Routine visits turn into medical crises simply because preventive care was skipped for too long. The system isn't broken. It's working exactly as intended, just not for patients. To understand how America's healthcare crisis deepened, you have to look past the hospitals and the doctors. Because while most Americans blame bad insurance or greedy drug companies, there's another silent force making it all worse: administration. Roughly 1 in every $4 spent on US healthcare goes to administrative costs. Billing departments, coding specialists, prior authorization teams, claims adjudicators, compliance officers. In no other country is navigating the medical system as complicated. The average American hospital devotes 25% of its budget to administration. In Canada, it's just 12%. In Scotland, only 8%. Why so much red tape? Because the US doesn't have a unified system. It has over 900 private insurers, each with different billing rules, coding systems, and provider networks. A doctor's office isn't just treating patients, it's also running a small bureaucracy, constantly submitting forms and appealing denials. Every visit, scan, or surgery can involve dozens of transactions behind the scenes, and every one of those has a cost. Hospitals now employ more billing clerks than nurses. A 2019 study found that the average American doctor spends 2 hours on paperwork for every hour of patient care. They aren't curing illness, they're fighting the insurance algorithm. Then there's private equity, the financial engine behind much of the chaos. Over the past 2 decades, Wall Street firms have quietly bought up entire chains of hospitals, ER staffing companies, nursing homes, and even fertility clinics. Their model is simple: buy cheap, cut costs, hike prices, sell high, and patients are the ones who pay for it. One infamous example, Envision Healthcare, a private equity-backed firm, staffed emergency rooms nationwide. But when patients showed up, they were often billed out-of-network even at in-network hospitals, resulting in surprise medical bills, sometimes exceeding $10,000. It was legal, lucrative, and disastrous for patients. It's the same pattern in nursing home. A landmark investigation found that private equity-owned facilities had more staffing shortages, higher mortality rates, and worse COVID-19 outcomes. Why? Because maximizing returns often means cutting corners on staff, on training, on food, even on soap. Meanwhile, the lobbying power behind healthcare dwarfs nearly every other industry. In 2023, healthcare lobbyists spent over $750 million, more than oil, defense, and tech combined. That's enough to ensure that even modest reforms, like allowing Medicare to negotiate drug prices, face enormous resistance. In 2003, when Congress passed the Medicare Modernization Act, pharmaceutical companies spent $116 million to make sure the government couldn't negotiate prices. The bill passed. Their profit margins exploded. And this isn't just about policy, it's about design. The American system is fragmented intentionally. Each layer, insurance, providers, pharmacies, middlemen, is a revenue stream. The more complex it is, the more money can be extracted at each stage. Simplicity would mean transparency, and transparency would mean less room for profit. Even health tech, often sold as a solution, has become part of the problem. Electronic health records, EHRS, were meant to streamline care, but in reality, they've become another layer of bureaucracy, filled with alerts, drop-downs, and fields designed to please insurers, not patients. Doctors report higher burnout, not better efficiency. The result is a system bloated with waste and inefficiency, yet razor-sharp in its ability to generate profit. Americans pay more, get less, and are forced to navigate a labyrinth of rules just to stay alive. Because in the American healthcare system, complexity isn't a flaw, it's a business model. By now, most Americans know the system is broken. They've lived it, yet somehow the system endures. Why? Because the myth of American healthcare is stronger than its reality. For decades, the US has sold itself the story that we have the best doctors, the most cutting-edge medicine, the fastest emergency care, and in some very narrow cases, that's true. If you're a Saudi prince or a hedge fund manager needing a rare surgery, America can be a medical paradise. But for the average citizen, that excellence becomes a lottery, and the ticket is your insurance card. This illusion has been reinforced by media and culture. In shows like House, Grey's Anatomy, ER, doctors save lives with near-miraculous precision. Insurance companies are rarely shown. Billing departments don't exist. There's never a scene where a patient is told their cancer medication isn't covered because it's been reclassified as non-essential. The drama is clinical, not financial. Politically, healthcare reform in the US has always been radioactive. Every attempt to expand public coverage is met with well-funded campaigns warning of socialism, death panels, or rationing. In 1993, the Clinton administration proposed a national healthcare plan. It was met with the Harry and Louise ad campaign, funded by the insurance industry, which aired over 1,000 times and painted the plan as a bureaucratic nightmare. It worked. The plan died. Profits soared. Then there's the issue of race and class. When national healthcare was proposed in the 1940s, Southern Democrats opposed it, not just on financial grounds, but because they feared it would force integration in hospitals. This cultural framing, healthcare as a consumer good, benefits powerful stakeholders. It allows them to say, this is just the market at work, even when the market is failing catastrophically. It's why insulin in the US costs 10 times more than in other developed nations, why hospitals in the same city can charge wildly different prices for the same procedure, why a broken arm can cost $7,000. Behind all this is a term you rarely hear on the news: medical capitalism. It's the engine driving this system, a belief that every facet of healthcare, from surgeries to scans to staffing, is a commodity. And if it's a commodity, then profit isn't just allowed, it's necessary. But medicine doesn't behave like other markets. Patients aren't rational shoppers. No one compares prices during a heart attack. There's no competitive bidding in the ER. That's what makes healthcare so uniquely exploitable. It's a service people can't refuse. And when the stakes are life or death, profit becomes predation. This isn't inevitable. Other countries have capitalist economies and universal healthcare. Japan has private hospitals, but the government strictly regulates prices. Germany allows private insurance, but ensures basic coverage for all. France has public and private doctors, but with a national fee schedule. These systems aren't perfect, but they're built on a different principle. Healthcare first, profit second. In 2009, a Harvard study estimated that 45,000 Americans died each year due to lack of health insurance. But that number barely captures the scale of systemic harm. Insurance in America isn't just binary, insured or not. It exists on a brutal spectrum of inadequacy. Underinsurance is rampant, affecting over 40% of of working-age adults. These are people who do have plans, yet still delay care, avoid prescriptions, or skip follow-ups because deductibles are too high or networks too narrow. The Affordable Care Act tried to narrow this gap, but insurers responded with thinner coverage, higher out-of-pocket caps, and labyrinthine provider networks. In essence, the insured became a new subclass of the medically vulnerable. Meanwhile, the profit incentives didn't just stay with the insurers. The entire medical ecosystem learned to bill like a Wall Street firm. U.S. hospitals hire consultants not just for care optimization, but for revenue cycle enhancement. That means upgrading billing codes, maximizing reimbursements, and sometimes flat-out manipulating charge structures. A single Tylenol can cost $35 in a hospital. An emergency room visit for a sprained ankle can yield a four-figure bill. These aren't glitches. They're design features. And what's worse, the more profit-focused the hospital, the worse the outcomes. Private equity now owns 1 in every 7 U.S. hospitals. These facilities have been shown to cut staffing, reduce charity care, and discharge patients earlier, all while raising costs. Even primary care, long considered the cornerstone of public health, has not been spared. In the 1990s, over 50% of doctors went into primary care. Today, that number is closer to 30% and declining. Why? Because it pays less. A cardiologist can generate over $2 million in hospital revenue per year. A family doctor, barely a fraction. Medical students graduate with over $200,000 in debt. They are structurally disincentivized to serve the public. And so, the very doctors best suited to prevent chronic illness and catch early signs of disease are now vanishing. Replacing them? Telehealth apps, urgent care chains, and algorithms. Fast, scalable, and impersonal. In reality, we have some of the best technology, best research, and best doctors, but access to them is controlled by a system built on exclusion and extraction. And yet, cracks in the narrative are starting to show. More Americans are questioning why insulin costs $300 here and $30 in Canada. More doctors are speaking out against burnout and bureaucratic bloat. Independent practices are forming co-ops. States are experimenting with public options. It's not a revolution, but it's a resistance. The system isn't changing fast, but the stories we tell about it are. And sometimes, that's where change begins. The American healthcare system may be sicker than its patients, but the people inside it, those who heal, support, fight, and refuse to give up, are not. And that means something, because systems don't change on their own. People change them. And if enough of us stop accepting this as just the way things are, then maybe, just maybe, this story can have a different ending.